Welcome to the Self Careapist podcast. Join me, Lorain Moorehead, a licensed psychotherapist, clinical supervisor, and EMDR consultant, along with expert guests as we explore the approaches and modalities we've used and developed to support our clients' success. Our conversations and stories are designed to inspire new and seasoned clinicians to stay curious, prioritize self-care, and never stop learning. Dr. Elizabeth McIngvale, LCSW, is the director of the OCD Institute of Texas, co-founder of MHNTI and adjunct faculty at Baylor College of Medicine. A nationally and internationally recognized authority on obsessive-compulsive disorder, Dr. McIngvale has published over 35 peer-reviewed journal articles, multiple textbook chapters, and is a sought-after contributor to national expert panels, media, and conferences. Dr. McIngvale founded the Peace of Mind Foundation and OCDchallenge.org, one of the first widely used online self-help tools for OCD, both now housed within the IOCDF. She has delivered over 100 public lectures and keynotes, facilitated dozens of national and international webinars. This episode is filled with knowledge bombs, from the symptomology of OCD and how it differs from OCPD to the most important treatment and assessment considerations when it comes to OCD, as well as her own lived experience and career and training trajectory. It's a can't miss episode. If this episode inspires you to want to read some of the books or take some of the trainings mentioned, head over to my website, lorainmoorehead.com/podcast, and download the learning tracker that features all the key resources from every episode. Welcome, Dr. McIngvale.
Thank you. So excited to be here. Looking forward to chatting.
Yeah, so happy to have you here. So we have clinicians that listen and are just going to be getting maybe more of a background on OCD and the things that come along with it, or might be getting the first background that they have in terms of a deep dive on OCD. So I think you're the perfect person to have here. Could you give us a little bit of a background on what brought you? I know this could probably take an entire episode on its own, but could you give a little bit of a background on how you arrived at the place you are now in terms of treating OCD?
Yeah, definitely. So I myself was diagnosed with OCD when I was 12. I lived here in Houston, same place I am now, largest medical center in the world, but we just didn't have treatment. And we went from provider to provider at that time and was told that they had never seen a case as severe as mine. There wasn't help available. And my parents really struggled, but continued to search because they're a parent who wants their kid to get better and doesn't want to believe that they can't not get better. But during that time, years passed, and years passing with someone with untreated OCD means severity increases. And so by the time I was able to get effective treatment, I was 15. At the time, my OCD was really extreme. And so I needed to go to residential treatment. At the time, it was in Topeka, Kansas, was the closest OCD specific res program in the country for adolescents. And so I went there and it changed my life, right? Every bit of it. Doesn't mean I did relapse and went back to inpatient later and kind of had a journey for a decade or so of really understanding, what does treatment look like? Like, how do I actually learn to manage my symptoms? What can that mean for me and for my future? But that first introduction to effective treatment truly changed my life and allowed me to understand that I wasn't alone, that I could get better, and that evidence-based treatment can save people. And my entire career followed. Like, there's no real way to say it except that I went into advocacy work. I became the first ever national spokesperson for the International OCD Foundation at the age of 17, and did a ton of public awareness advocacy campaigns talking about what OCD is, OCD treatment, and knew that I wanted to do this work. I never really questioned what I wanted to do. I felt really called to it, as most of us in mental health do, in different ways. And so went a couple different routes, did some work in academia for a little while. I was at Baylor, and then was doing some academic and clinical work at Baylor College of Medicine, and then ended up back in a OCD res setting. And now I'm the director of the same program that saved my life. So it now is in Houston. It relocated, and we're now independent from the Menninger Clinic, but for all intents and purposes, it's the exact same program. And it's just this really amazing full circle for me to be able to be here as a clinician, as a director with lived experience, doing the work that saved my life.
Oh, wow. I didn't realize it was the same program.
Yep.
What were some of the key elements of that program that you believe in so much in terms of making a difference in treatment.
Yeah, I mean, we know for OCD, you need evidence-based treatment, which is a specific form of cognitive behavioral therapy called exposure and response prevention, also known as ERP. And so it's what the program was based in and rooted in back when I sought treatment, and it's certainly still what we follow. Of course, there's been lots of adjustments. ERP looks very different now than it did 10, 20 years ago. But for all intents and purposes, it fundamentally is the same, right? It's rooted in CBT and the understanding that our behaviors impact our beliefs and our feelings, and we actually do have the power to change those.
Yeah. What is, for anyone listening that's curious about the training process, what does it look like to get trained in ERP?
It's a good question. And if you had 20 ERP specialists on here, they would probably all answer differently. So bear with me. But, I mean, really what I want us to be thinking about is yes, of course, there's 2 and 3 day intensives. There's books you can read. There's ways that you can get some good base knowledge in ERP. I would say certainly you need to have a good base knowledge in CBT first. So, like, you really need to understand mechanisms of change and how cognitive behavioral therapy works, and really the premise behind it to understand ERP, because ERP will fold into that nicely. But I think most of us would say in order for you to really be specialized, you need to have worked in a specialty OCD clinic. And there's very few of us in the country, but if you really are working hand in hand alongside the most severe cases with the most equipped team, really getting that continuous team and clinical supervision and oversight, that's how you're going to get true training. Otherwise, we want you to, at minimum, be doing like a intensive training. There's Behavioral Therapy Treatment Institute and Training Institute through the International OCD Foundation has a 3 day OCD specific training, and lots of ways you can get OCD and CBT specific training to get a good base. And then no matter what, you need to be getting some supervision and consultation with individuals who've had decades of experience working in this field.
Yeah. Is the supervision and consultation piece built in like a certification track, or is the clinician more responsible to seek out those pieces or be at a facility that offers that?
Yeah, it just depends what route you go and what training you're getting. So BTTI through the IOCDF does have 3 consultations built out that you have to do with the same person who led your small group. That faculty member will do those 3 consultations. But 3 consultations isn't going to make you a specialist, right? That's not going to do much. It's going to build a good base and like help you
Mhm.
work through one case and understand and think through OCD in a much more detailed way. But ongoing supervision would be up to you. Myself and an amazing colleague, Dr. Lauren Wadsworth, who also specializes in OCD and identity and diversity work. We actually recently just launched a mental health training app called MNTI, and it's the Mental Health Network and Training Institute. The concept behind this app is just that, actually. So we've got leading experts from across the world are, giving presentations that are CEU eligible. You can get your CEs through the app in content areas, but then we have ongoing group consultations. So as part of the subscription, you can get group consultations and join group consultations from different leaders in different fields. So, okay, this week I had a new patient who's presenting with some mania and I want to, understand more about bipolar. Or this week it's really scrupulosity subtype of OCD. Let me do a group consultation in that arena. So there's platforms and places where you can have this one-stop shop to get continued training resources. Not a lot of them, but some of them are out there, and be able to do ongoing group consultation. But as you know, typically it's really something a clinician needs to seek out.
Yeah, that makes sense. It's neat to hear about Menti, and I love the pronunciation
Thank you.
of it
Yeah, we're
too. Yeah.
excited.
Yeah. How new is that platform?
We launched a week ago, so we're very new.
Oh,
Yes, so exciting. Thank
congratulations.
you.
What other types of specialties do you have represented on there so far?
Yeah, great question. So right now, Minty is mainly focused on depression, CBT, anxiety disorders, all anxiety disorders, and BDD, OCD, and we are in gender and diversity and inclusivity is an important piece too of how to integrate that into clinical practice. And then we're going to be building out every area. So, bipolar, thought disorders, mood disorders, substance use disorders, and then even platforms that we're going to build out in sections will be focused on like how to build a private practice and how to build an intensive program, right? All these different questions that those of us as clinicians often have that we don't get answered. And but the goal of Mentee is for you to be able to get specialty training. And if you're a specialist, to have a one-stop shop where you can meet your training needs when you have differentials that are presenting in front of you, right? No clients anymore show up with just one disorder. all the time, right? You may say, oh, I only treat OCD and that's my specialty, but 100% of your caseload isn't going to have just OCD, right? Maybe a lot of them have just OCD, but a lot of them also have a ton of very common comorbidities with OCD. That's often going to be anxiety disorders, depression, substance use disorders, autism, spectrum disorders, right? You name it.
Yeah, so true. And when you're seeing this complex comorbid diagnosis, it makes sense to be able to expand your training in that specialty area in order to continue to provide that continuity with your client.
Exactly. Yeah. And it's just so important. And I think so many of us as clinicians just continue to fall in this rut of like, well, where do I go? Right. And it feels like training is often piecemeal together. We're having to like go to one place to get this, another place to get this, and, last minute scrambling to get our CEs versus it being something that is really like just a part of our continued growth and something that we're getting CEs for trainings that we really value versus just getting them for check marks to get our license updated.
Yeah. So you couldn't have said it better. I think that's part of the mission that I have here as well, that um, access to interesting learning beyond what you might usually be exposed to is what continues to make our field grow and develop. And there are a lot of ways to scramble and get those CEs accomplished before your licensure deadline. And are you always taking those and applying them to the next year if that's what you've done? So access to really high level CEs, I think, is so important.
Yes. Couldn't agree more.
Could you describe, I guess I haven't even asked you to give a great definition on what OCD is.
100%. Yeah. So OCD is obsessive compulsive disorder. And I like to talk about OCD very broadly as well, in the sense that I want us to think about what OCD truly is in a clinical domain and with patients we're seeing versus what society often labels OCD as, right? So we can talk about both today. OCD is obsessive compulsive disorder. So that means it has two components: obsessions and compulsions. These obsessions are unwanted intrusive thoughts. So these are not thoughts that individuals are fantasizing about that bring them enjoyment or pleasure. These are thoughts that are disturbing. These are thoughts they don't want and thoughts that they want to get rid of. And so, in an effort to get rid of that thought or get rid of the distress that the thought brings on, individuals engage in compulsions, also known as repetitive behaviors or rituals. These rituals are also not enjoyable. The patients don't enjoy any part of the ritual, any part of the behavior. They do it because they feel like it is the only way for them to feel better, right? It is really a means to end their anxiety or their intrusive thought. It is not an activity that they enjoy. Oftentimes, individuals, clinicians, and society really misdiagnose OCD and OCPD, right? OCPD is obsessive compulsive personality disorder, very different than OCD. OCPD is what a lot of people and what I think society thinks of when they think of OCD, right? OCPD is when we hear people saying things like, oh, you should see my coworker's desk. She's so OCD. Or you should see my husband's closet. Like, he's so OCD. Things have to be color coded. Very different than OCD. Well, why? Number one, oftentimes, even if it's annoying to them and they don't like things being out of order or not in a system that they've organized, the behavior itself, right? So organizing things, getting it color coded, having their desk organized a certain way, individuals will talk about it actually helping them, actually being functional for them, right? Oh yeah, well, it makes it a lot easier if my clothing items are color coded or organized by style when I get ready in the morning, because it's easy for me to know where stuff is and easy for me to write. So it's a functional behavior, even if the organization is kind of annoying. OCD behaviors are not functional, right? Someone who is washing their hands to get rid of an intrusive thought, that hand wash is not functioning as hygiene. It is not functioning in a way that other people would say, oh yeah, they actually should do that. Like, that's actually useful. It is functioning only to reduce their anxiety and their intrusive thoughts. So really, really important key differentiator is that there's never enjoyment, there's never pleasure, and it's not functional for individuals with OCD to do these behaviors versus OCPD. So my favorite slogan that my nonprofit came up with a long time ago is OCD is not an adjective. And I think if we can just title anything that's like the best way to explain OCD. So if you're using it as an adjective to describe someone or to describe behaviors they do, that's probably not OCD. That may be more in line with OCPD, where OCD is disruptive, it's debilitating. It's one of the top 10 reasons people file for disability worldwide. It costs the US economy like over $8 billion in lost productivity. takes individuals on average somewhere between 10 to 14 years to get proper diagnosis and treatment. This is a really debilitating illness that impacts all assets of individuals' quality of life. It is not a quirk. It's not, what you see on shows where it's depicted in this like funny way that doesn't really impact their life. This really impacts people's functioning.
Yeah, I think that's so important. And I think probably anyone listening with experience just sighed of relief to hear you classify it in that way. Yeah, it's not a dating profile slogan if we're looking at true OCD symptomology. There are a variety of types of OCD. Uh, is that a standard number or is it relative to, again, the different 20 experts that you're speaking to?
So it's interesting. So subtypes of OCD are really classified and differentiated based on core fears. So what is someone really afraid of, and do a lot of their symptoms present more in a realm of contamination or scrupulosity, the religious form of OCD, or hyper responsibility, fear of harm coming to someone else, right? That maybe you doing checking behaviors or different things. So I think there's probably about 8 to 10 subtypes. Most of us would agree on what those are. Um, and there is always room for variability and nuance in those. So sometimes one person will describe harm OCD as another person describes it as moral or scrupulosity OCD, depending on how that patient presents and what they're actually afraid of, right? Are they afraid of harm, or are they afraid of if they harm someone, God wouldn't forgive them, right? Like, what is it actually rooted in? The good news is it doesn't really matter, right? If someone has OCD, most patients, a lot of our patients will have one or multiple subtypes at different times in their life. And so we don't that yes, it matters in the sense that when we're treating that patient, we want to be able to target their specific fears, but treatment doesn't change, right? ERP still works for any type of OCD. The concepts of helping patients learn how to truly change their entire relationship with anxiety and OCD stays the same. So, I think that it's important for us to know, oh yeah, OCD can look and present in a million different ways and in a million different categories, but it doesn't really change. It doesn't impact outcomes, or it doesn't mean that like as a specialist, you can only specialize in contamination or you can only specialize in scrupulosity. Like, no, you specialize in OCD treatment and you can treat any type of OCD.
Are there subtypes that you think are more commonly missed during the assessment process or treatment process?
Totally. Yeah, totally. I mean, first and foremost, I think contamination OCD is one that people most broadly know about. So they think that's
Mhm.
the most common form of OCD, or that's what we're most likely to see. And that's really not the case. We don't like have a reason to believe that people, present with one subtype more than the other. Um, Taboo OCD themes would include like sexual intrusive thoughts, harm intrusive thoughts. Those are often misdiagnosed, misunderstood, and also something that patients hold back a little bit, right? If they don't feel as comfortable or like, talking to you about it, and they haven't built good rapport or trust, or you haven't presented that as something that has been normalized for them, they may have a lot of anxiety talking about those subtypes because they're just more taboo in nature, right? People are more anxious and more concerned about, what are you going to think of me? Are you going to think I'm going to act on those thoughts? Where we know people with OCD with these thoughts, if they're OCD thoughts, they're the least likely to act on those, right? They're terrified of these thoughts. They're scared of them. There's no intent. There's no history. But people are more afraid, of course, to talk about them if they're not already in a space where they feel like that would be a safe space to do so, or where it's normalized.
Yeah, that makes sense. I am a perinatal mental health specialist, and that reminds me a lot of when we're seeing postpartum anxiety or OCD.
Right. Exactly. Yeah. So postpartum anxiety and OCD is so common. And it's
Mhm.
so clear, right? You can tell such a difference between postpartum OCD and other things because these are moms who would never harm their kids. They are terrified of harming their kids. And like if it's showing up as harm OCD, and they're taking every measure to make sure they would never do that, right? This is someone with no intent, no history. They're terrified that they're having the thought versus, oh, I'm kind of fantasizing about the thought, or I'm having thoughts of doing this, and I don't know if I would act on it. It's a very different presentation.
Yeah, I think what we see in the media is often, of course, not postpartum OCD. It's more along the lines of postpartum psychosis. But I think exactly what you said, that what really matters is, are they seeing that it's a thought that feels completely out of character, feels scary, feels harmful. That's a big difference in how to move forward with that diagnosis for sure.
Exactly.
What would you like to see clinicians doing more or less of when it comes to OCD?
Yeah, I mean, I would love for people to do more assessing, and less treating. You're gonna think that's weird, but I mean that, like, I think that clinicians need to be really, really thoughtful about what's their wheelhouse, what is their specialty, and if you are not an OCD specialist, please refer out. Please quit trying to treat a patient that you're not trained to treat. And this is just such a problem in our field, right? We see this time and time again where you can go on Psychology Today and look up a provider and they say they specialize in 35 things. And those of us that are specialists know that that's not possible, right? There's not enough years in your life to have gotten appropriate training to be a specialist in multiple things. Now, could you be a specialist in 3 or 4 things or 5 things that are treated in the same realm? So, like, right, I can specialize in OCD and all the different anxiety disorders, and then obviously have some good training and background, and I can definitely treat depression and BFRBs and comorbid conditions. Yes, of course, because the treatment is all the same, right? I specialize in CBT, I specialize in exposure and therapy, and I specialize in ERP, exposure and response prevention for OCD. But I really want clinicians to assess better, right? Do good assessments, really do good measurements, figure out exactly what your client's presenting with, and be really thoughtful about if you should be taking on that case or not, or if you should be referring out. Because the only way we're going to lessen the gap for patients who live with any disorder of that gap between symptoms, appropriate diagnosis, and appropriate treatment is for clinicians to start doing a better job of assessing and referring out and only treating when it's within their area of expertise.
I love that. I think that's so important and gives incentive for folks to really dig in and specialize
Yeah.
in some of that advanced training.
Yeah,
Um,
my favorite feedback I got from one of my grad school professors a long time ago was, I want you to look at every client as if you have a long active wait list, right? If you have a wait list of people who want to see you in your area of expertise, would you still be seeing that patient? Is it already time to terminate with them, or would it be time to refer them out, or would this be a patient you shouldn't take on? Those are all questions you would ask if you had a really strong active wait list.
Ooh, that's so good. There's so many good quotes that I'm going to be pulling from here. You mentioned the assessment process and you mentioned measures. Are there particular measures that you recommend in a thorough assessment of OCD?
For sure, yeah. So for OCD, the most validated measure we use is called the Y box, the Yale Brown Obsessive Compulsive Scale. This is a quick measure that really looks at OCD symptoms in terms of obsessions, compulsions, and time spent, and it will help put people in categories and level of severity. So, subclinical, mild, moderate, severe, or extreme. And this is really useful. It's a super quick measurement tool. If you are a CBT specialist and you've done some OCD training and you've read a couple books and you are wanting to treat a patient and they're presenting with mild to moderate OCD, maybe you could treat them and maybe they'll really benefit from you being able to use interventions you've learned through some of your softer touch points of OCD training. If someone's in that moderate severe to extreme range, you really need to be thinking about that, right? Severe to extreme probably should not be treating them. And even if you're an OCD specialist, you shouldn't be treating a patient usually with extreme OCD outpatient. They need a higher level of care. You need to be talking to them about PHPs and residential programs and programs that are really going to help them, because the worst thing we can do is have a patient think that they're doing ERP for their symptoms and they're not getting better. And then they think that ERP doesn't work for them, treatment doesn't work for them. They feel hopeless. We've increased that kind of real defeated feeling versus them understanding, oh, ERP could work for me, but because of my level of severity, I need it at a higher intensity right now. And I need to start at that higher intensity and then step down to outpatient.
Yeah, that makes sense. Would you say that that is one of the bigger risk factors that you see at the inpatient level of care if someone has started with a provider that isn't fully trained in ERP?
I think the number one thing we see is comorbidities. When we're treating people, I run one of the few residential programs that are it's OCD specific in the world. And so a lot of our patients that come to us are coming to us with an OCD diagnosis. And unfortunately, they're often having a lot of other comorbid diagnoses that have not been diagnosed, treated, or assessed. And so, we're seeing that, like, yeah, ERP alone didn't work because they don't have just OCD, or like you were using ERP for not OCD symptoms, right? This is personality disorder symptoms, or, maybe they have autism or other things are going on. The second thing is we're seeing a lot of untrained OCD clinicians that are treating patients. So patients will say ERP doesn't work for me. And when they come, what we're actually seeing is that, yeah, like that wasn't good ERP, right? That wasn't ERP that was values based. It wasn't ERP that made sense. That's not how we would do ERP treatment. And so a lot of providers are getting this little bit of ERP knowledge, and then they're just kind of jumping on, into the pool without really knowing how to swim, and like trying to like doggy paddle their way to the side, which like sometimes it works and it can make some movement, but it's not actually like the way to make significant change, right? And have significant outcomes.
Yeah. Can you explain what values-based means to you in that
Yeah,
context?
absolutely. So when we think about ERP, it's really exactly what it sounds like, right? It's exposure with response prevention. So patients with OCD need to be exposed to the things that they're avoiding, the things that trigger them, right? So I'm afraid to touch that item because I think something will happen, or I'm going to get contaminated. And if I got contaminated, I could get someone else sick, whatever it might be. So the exposure is going to be touching the item. We can all kind of agree with that universally. That makes sense. Response prevention, which is the most critical part of OCD treatment, more important than an exposure, is that patients have to prevent the response they typically would do, right? So if that patient would typically go wash their hands, we need them to not wash their hands, right? We can all understand that, yeah, if they touch that thing, but they go wash their hands, they reinforce the cycle versus can they touch that item and not wash their hands, and teach themselves eventually, the more they do that, wow, I don't need to be afraid of touching that item. I can do that, right? It's not no longer as scary if they keep doing it. Their feared response, their anxiety levels will reduce. They'll habituate. In the old days, when we did ERP and we would kind of figure out what are things people were afraid of, we kind of had this like fear factor approach where it was kind of like, okay, let's just see how anxious we can make people and have them do all sorts of exposures that'll make them anxious, and teach them that, like, yeah, you can get anxious and it doesn't matter, and you can do these things that are scary. But the problem with that is that majority, if not a lot of the time for sure, a lot of these exposures didn't align with someone's values, right? If I have scrupulosity and I'm afraid I'm not going to go to heaven, let's just say that's one of my OCD fears. And so I do lots of different, rituals and avoidance behaviors and all the things related to my faith, whether it's around prayer, church, and numbers, and you name it. Going and throwing rocks at a church, I guess that could be exposure, and I guess I could do response prevention. I'm not saying a prayer after I do it, but it's not aligned with my values, right? I can probably say to you, if I'm that patient, that like that's not something I would normally do. Like that's not something I really would feel good about. It's actually something that goes against what I want, which is, to have a good relationship with my faith and to be a strong Christian, right? If this is what how someone's presenting. And so values based ERP is really saying, okay, Lorain, like for you, what are you avoiding? If you didn't have anxiety or OCD, what would you be doing? And often those patients will say things like, well, I'd start going to church again, right? I would join a small group. I would not avoid praying. I would be willing to read scripture in the morning. I used to love doing that, but now I reread it and I get stuck and it's anxiety provoking, so I avoid it. And so the exposures that we do, we want them to be aligned with their values, right? So what's the best exposure for that patient? It's going to be having them do things that they're currently avoiding, that they wish they could do, that their OCD and anxiety have taken them away from, right? I want to get them back to church, back to reading the Bible, back to engaging in small groups and doing those things that they really want to be doing, but they've been avoiding because of their fears.
Such a good distinction that it's not what can we get you to do now that we've released some of
Yes.
this? It's like, what would you actually want to? I mean, DBT would call it a life worth living. What would that actually look like?
What would that look like? What do you want to be doing? And that's what it's funny because I'm in a lot of these Facebook groups, or I do a lot of consultations, and the question we get asked all the time, those of us doing this work, is like, okay, I have a 33-year-old patient presenting with this OCD. What exposure should I do? And I like every time I see it, I cringe, but I also respond, and I'm like, how would we know? Ask the patient. Like, I don't know what exposures you should do because every patient, I can have 10 patients with that same exact presentation and they're
Yeah.
all going to be doing different ERP, because the answer to that is like, ask your patient, like ask them, like, what are you avoiding? What do you wish you could do? What would you be doing if you didn't have anxiety and OCD, if you weren't overcome with this fear? And they're going to tell you the things that they wish they could be doing that they want to get back to. And guess what? I know it seems shocking for some providers, but like that's what they're going to be most motivated to work on and most willing to do the work around, because ERP in and of itself, exposing people to triggers, having them do response prevention, it's very triggering. It's very anxiety provoking. It's hard work. This is not fun therapy. This isn't therapy that patients come in and you chat and you have a sparkling water and sit on my couch and you leave smiling. Like, patients are crying, they're anxious, they're triggered. I'm having them do really hard work. I'm having them face things and approach things they've been avoiding for years or decades of their life. And so if it's not aligned with their values and they don't see the purpose of it and they're not kind of wanting to do it more than I want them to do it, we're not really going to get anywhere.
Oh, yeah. It feels like there really is a balance that skilled clinicians strike between safety and, I don't know, comfortability,
Oh,
where they're making an improvement and they feel safe and they're not going at a faster pace than, tolerability maybe improvement and tolerance for the treatment.
and trust and rapport and right, like
Oh,
I'm
yeah.
going to have you, like I'm teaching you to be comfortable being uncomfortable. Like I am going to teach you to be willing to feel distress. That is a part of the treatment model. It is a part of our treatment method. And you need to be more willing to do that than I'm asking you to be.
So interesting to hear from someone who's sort of seen things from both sides over the past and the evolutions of the modality through the years as well. Do you have a resource that allows people to make referrals to clinicians who are up to the task of treating complex OCD cases?
Yeah, yes and no. This is a tough one. Minty will. We're getting there. So Minty's actually, we're really excited. One of the things we're building through the platform is a find a provider tool that's going to be one of the first ever data-driven find a provider tools. So it's really going to allow you to understand, like be able to say OCD and then put the zip code and then be able to understand how to appropriately filter someone's years of expertise, like certain trainings they've done and know what it means and feel good about the referrals. Right now, that doesn't really exist. And the best we have is the International OCD Foundation. If you go to iocdf.org, we have annual conference and webinars every week that we do from clinicians and also for community members. But they do have a find a provider tool. So you can go to iocdf.org and go to their find a provider tool. However, as with most find a provider tools, it's up to you to do that work and figure out if they're truly equipped to treat OCD. So you want to look at where did they get trained? What is their specialization in? How many years have they been doing this work? That sort of thing before you refer. I
Very.
also have a video on our Menti platform that will be up soon. Each category will have a video that's like a free video, even to the public. So for individuals with OCD, anybody can access it, where that free video will walk through like, what is the diagnosis of this disorder? How do you understand it? What does it look like? What should treatment look like? What do you look for in a clinician? How do you know if someone's equipped to treat you? So we're working on really providing that super strong and sound educational content for every disorder available to the public, because I just think that's such a needed thing where most people have no clue what they're looking for. They go to Psychology Today. Someone says they treat 30 things. They assume that means they do treat those 30 things, because why would they know any different? And they get there and realize that's actually not the case at all.
Yeah, I think that's a great point, especially with the introduction of unlicensed professionals or not eligible for licensed professionals that have a platform as well. I think it's great education for the public to know what qualities and qualifications might really allow me to find a provider that knows how to treat this.
Exactly.
Switching hats a little bit, how did you get started in the tech and development pieces of your career?
Oh goodness. So I think that actually it's interesting. I started a long, long time ago. I first started my career with a nonprofit. I started the Peace of Mind Foundation, peaceofmind.com. It's now a part of the International OCD Foundation. But when I first started it, we really had this mission to increase access to care for individuals living with anxiety and OCD. And so at the time, we started a self help website called OCDchallenge.org. And it is and was a free self-help website for individuals living with OCD that kind of helps walk them through the basic principles of ERP and build some good foundational skills. We all know as clinicians, like self-help is never going to replace in-person therapy, right? It's not better, but it's better than nothing, right? I'd rather have someone be able to get access to self-help materials that are rooted in evidence-based care than somebody, end up with someone who isn't doing evidence-based treatment. And so I kind of started in that realm. And for me, a lot of it was about how can tech leverage access to care. Now my career has shifted a little bit where I do a ton of the obviously like treating the most severe cases and really, really doing in-person ERP. And I wanted to still use tech to leverage mental health care. And I think one thing I kept running into, as you know, as well as a clinician, is this just need for really good training. It is so hard for clinicians to continue training, but also to get basic training. Just because you went to school and got a degree doesn't mean you actually got good training at all, right? We unfortunately know that a lot of these grad schools are, the education is super outdated. It's very rarely specialized because it's broad, right? They're really trying to give you like these broad points. You get your specialization through internships, through placements, through your continuing ed. That unfortunately, a lot of people can kind of skip around or not have access to good training. Like some people don't have internships that were really good and immersive or specialized, and they really lacked that. And there's a huge need for it. And so that's actually why Lauren and I developed Mentee is we just felt like there was not any place that we could soundly tell any of our clinicians or trainees that come through our programs, hey, go to this one place and this is where I'd recommend that you go to get continued ed, to get your CEs, and to be able to do consults that we would feel good about. And so one of the things Lauren and I kept saying is, wow, one thing our team really values is that we really know the OCD and anxiety world very well. That if a clinician comes to me and says, hey, Liz, I really want to meet with John Abramowitz because I really want to learn more about inhibitory learning. I'm like, okay, great. I'll start an email thread with y'all and like, he'll meet with you. No problem. He's awesome. Like, you're in great hands. And people have always been like, oh, that's so amazing. I don't know, like, how you know these people? And it's like, oh, well, just conferences and connections. They're actually like everybody's super humble and like loves to help each other. That's how we are in the OCD field and world. And I realized that there's so much to be said for having access and leverage to these experts that so many people would love that. They would love to know that, wow, if I want to learn more about depression or exposure therapy and I can go on Mentee and hear from Edna Foa and book a consult with her, like that's amazing. Like, how else would I find Edna's info and be able to book a consult with Edna Foa? Like, those things is what the goal of Mentee is really curating. And so to answer your question of how I got into it, we kind of stumbled upon it, right? It was just like, man, there's this problem. And Lauren and I at first were like, should we do OCD specific? And then we were like, no, this should be for all mental health. And we should bring in leading experts that people otherwise wouldn't have access to, that they get to learn from. They get their CEs. And by the way, it's also a CE management tool, which we're excited about. So you can upload other CEs that you've gotten and it'll keep it all in one place. But it all goes back to our same goals. Lauren and I have this shared goal and mission that we can increase access to evidence-based treatment. And there's really no better way than to leverage that in a web and mobile platform and app that's available to clinicians. Because if I can, really train one clinician on evidence-based interventions, they can go treat hundreds of patients versus the hundreds of patients I can treat on my own.
Yeah. It's so cool. I can't wait to check it out more.
Yes. Yes, for
Really
sure.
neat how I agree. I think hearing from an expert is just a different thing, and it allows you to get excited. It allows you to know, to your point, in grad school, you are introduced to what your professors are familiar with. You're introduced to the modalities that your school offers a class on, and then the same thing for your internship. And so you might get down the road and not even know, I mean, what someone listening right now might not even know what treatment is ideal for OCD.
Totally. And the reality is that like you shouldn't know everything because it should change, right? When I graduated grad school 18 years ago, I hope treatment's different now than it was back then. So even if I had great training in grad school, I need new training now because it's almost 2 decades later and things should be drastically different.
So interesting. Is there anything on any of these topics that you should mention that I haven't asked about?
Not really, no. We'd love for anyone who wants to learn more about OCD, go to iocdf.org. It's really our international foundation. I serve on the board of directors there. It's really kind of our governing body on OCD, OCD education, OCD treatment recommendations, really is published and pushed through the foundation. So we have great resources there, continuing ed courses, kind of you name it, but also an annual conference, lunch and learns, lots of education. And then, of course, please check out the MHNTI platform to learn more about evidence-based interventions. And you can always find me at OCD Institute of Texas. Again, we're one of the few residential OCD-specific programs in the country and in the nation. And country and the nation, same thing, right? But in the country and in the world. So definitely, if you have a patient who's in need of a higher level of care, you can always check out our work at ocditexas.com.
That's great. And my final question, given all of the hats that we've just learned that you wear, you may not be the top proponent of self-care, but is there a type of self-care that you often recommend to your clients or anything that you routinely pull in for yourself?
Yeah, I'm never a good person to ask. I've got a lot of work and things going on and 4 kids 4 and under. So
Are there
my
twins
life,
involved to
the
make
twins
that
are, yeah,
happen?
5 months. So,
Oh, oh my gosh.
exactly. Yes. So
Congratulations.
thank you. Yeah. So life's a little wild, but no, I mean, listen, self-care is about finding a way to disconnect and to get your rhythm, kind of, that's what I'm going to call it, right? But to regulate. And what we know about regulation, I've learned from Dr. Bruce Perry, who's, undoubtedly in my mind, the best trauma expert and someone, if y'all don't know his work, look into it, right? Is regulation typically takes about 2 minutes. So I think a lot of us have this belief that, oh, self-care means I need to go spend like 5 hours at the spa or like all day hiking or, I need not necessarily, right? Regulation can be taking a 2-minute break that you just go on a quick walk or you listen to music, right? Or you do something to get kind of your circadian rhythm, but like rhythm and different things can allow and increase regulation. Movement steps can be a big part of that. And so for me, self-care is a little bit here and there, right? It's being able to get my kids down for bed and spend 5 minutes doing something for myself. At work, my self care tends to be a coffee, like making a latte and drinking it and having a moment to enjoy it. But you have to figure out what that is for you and what works in your schedule, and recognize that self care needs are different for everyone.
Yeah, so true. All right. Well, thank you so much for your time today. You're such a wealth of knowledge. I think we packed. I was just thinking all the show notes I'm going to be writing with all the links that you provided us. I was a jam-packed episode, and I just really appreciate your time today.
Thank you so much. It's been a pleasure, and I hope to hear more about all the awesome things you're doing. I'll continue following along and sharing, and yeah, look forward to hearing from all your listeners in different ways.
Thank you so much.
Thank you.
I hope you enjoyed this episode of the Self Careapist podcast. If you did, please subscribe and feel free to leave a review. You can also follow along at the Self Careapist on Instagram or head to lorainmoorehead.com/podcast to grab a free copy of your own learning map worksheet to help track all of the tools and strategies you're interested in learning more about. See you next Wednesday.